Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Dr. Cedare Ziai and myself, Dr. Guillermo Rocha. We'll share our experiences as ophthalmologists today and tackle some challenges we face as healthcare providers. Are you ready, Cedare?
Let's do it, Guillermo.
On today's episode, we'll get an update on COVID-19 and discuss how we should view this second wave, what we can expect, and what we can do to overcome the challenges we will inevitably face. We'll also talk about what to expect in a potential vaccine and when we might see one in use. Our guest is Dr. Jim Chodosh, a clinician scientist internationally known and respected for his work on molecular virology, viral genomics, and viral pathogenesis. In addition to serving as the Associate Director of the Cornea and Refractive Surgery Service, he directs Boston Keratoprosthesis Programs and serves as Vice Chair for Ophthalmology Education at Harvard Medical School and Associate Chief of Ophthalmology Education at Mass Eye and Ear. His clinical interests include ocular infections, chemical burns, Stevens-Johnson syndrome, and keratoprosthesis surgery. In other words, all the really tough stuff. Dr. Chodosh attended medical school at Baylor College of Medicine, where he also completed his residency. He served his fellowship in corneal and external diseases and surgery at Bascom Palmer Eye Institute. He leads his field in so many ways, we can't really fit them all into the podcast. I think all I would say is that if you want someone to talk at a podcast when we're in the middle of the pandemic, who has experience in virology, epidemiology, and tough cases in ophthalmology, you couldn't ask for a better guest than Dr. Jim Chodosh. Jim, how have you been?
I've been good. I think the most important thing right now is to remain safe. That's what I keep telling everybody. In the coming months, you have one job, and that's to stay safe.
Yeah, you've been key in spearheading the American Academy of Ophthalmology Coronavirus Task Force. And I was reviewing some of the lectures that you gave at the past meeting, and there was something that you said in terms of, should we call this COVID-19 or COVID-19 20 and 21? What did you mean by that?
Well, the disease is coronavirus disease 2019, but clearly we're in the year 2020 and it's still roaring. And it appears that we will still be losing lives due to this disease in 2021. I hope it ends there. I think maybe we should have a different name.
I was also reminiscing that about 8 months ago, you and I had a really good conversation. You helped us launch our Path to New Vision webinar series from the Canadian Ophthalmological Society. You gave us a lot of really good tips, a lot of good insights on the virus and how to protect ourselves. How do you think your perception of the measures or your perception of what you are implementing in your daily life has changed, or has it changed at all since that time, Jim?
Yeah, I think that recognition that this is really an airborne virus as opposed to a contact or a fomite acquired virus has become more certain, so that measures to constantly clean and disinfect, to not touch things, to wear gloves are, I think, now considered perhaps not unimportant, but less important than managing the air in the rooms we live and work in. And that really comes down to, seeing patients. I still believe and certainly still disinfect all the surfaces where a patient either contacts or breathes on in the room and anywhere that I touch repeatedly, which means that I disinfect my slit lamp between every patient encounter, and I disinfect the places where the patient touches, not necessarily the seat of the chair, but the armrests at every encounter. It also means that when the patient is comfortable with the privacy issues, or when the clinic is uncrowded outside the exam room, that I like to leave the door open. It's very expensive, for example, to know what the turnover of air is in your exam room. Having that analyzed is incredibly expensive. So in absence of that, you have choices to increase the ventilation, keep the fans on, open the door, and there are purification units that you can buy if you are someone with a pre-existing condition or at an age where you're even more worried. But I think we've become less concerned about contact spread and more concerned about airborne spread. And that's consistent with all the other coronaviruses. It's consistent with all the other respiratory viruses. It just makes sense. I think it's just that in the beginning, in the first surge, when we saw so many people getting sick, seemingly with so little contact, that the concern was we had to do everything we possibly could to reduce exposure. And now that the dust has settled, so for example, I'm not afraid to push an elevator button, but I use my knuckle instead of my fingertip because I'm unlikely to rub my eye with my knuckle or my nose. So, there are certain measures I take to reduce risk. If it's a place where I don't know if someone has just sneezed in their hand and touched that door handle, then I'm more careful, obviously. But those would be the situations. The virus, still, the evidence for the virus remaining viable for much time outside the host is not very good. On the other hand, the evidence for the virus being transmitted by an unmasked person who's speaking, eating, or singing, for example, is quite good. So taking that into account, I think we need to recognize it's the air we breathe that we need to think about less so than what we touch.
So along those lines, we know a little bit more about that, and certainly we know about more in terms of the airborne effects of the virus. How did we get here? We knew back in 1918 there was a second wave, and even at the beginning of the pandemic, we were talking about a second wave. Where did we miss the boat as, I would say, the great majority of the countries? How did we miss it? There are some countries that have done well, but here in North America, not so well, and certain places in Europe for sure.
Well, I have my theories about this. So I think part of the problem is our liberal societies, and I'm not sorry that I live in one. We have independent thought in our societies, and we have freedom of mobility and action in our societies that I think make it difficult, even in places where mask wearing was not politicized, for example, make it difficult. There's also fatigue. In Massachusetts, I think that the state government did an exceptional job of tamping down the first surge. We had a big outbreak. And I think that the population has been very receptive overall to mask wearing and distancing. But I think people are tired of it. And now we're entering the holiday season. And the outbreaks in my little town, which is just outside Boston, have all been related to social gatherings at a yacht club, at a golf club, Thanksgiving dinners. They've all been, close but small gatherings in which somebody was infected, and the masks were off. People were eating and drinking and talking.
Wow, yeah.
And that's how it goes. So I think a lot of it is fatigue, but I also think it's also a reflection of our society. And I'm not unhappy to be living in such a society. It's just a society that's particularly susceptible. I think that outside of the Northeast, in many parts of the country, in the U.S., the virus was so politicized at the federal level that it became really impossible to convince people that it was real. They needed to take measures. People saw it as an individual liberty rather than protecting others, which was a huge error. And I think we can fault leadership. It's interesting. I had a moment to reflect on this. I was preparing a talk on COVID very recently, and the New England Journal of Medicine published an editorial very, very critical of the U.S. federal effort on COVID-19.
Yes, I remember reading that. Yes.
Yeah, and it was a remarkable thing because it's something that they never had done before. Come out so critically of the federal executive level of government. And I really think that in the U.S., our leadership, and I credit them for this in certain ways, they went for the bright, shiny object as opposed to the small, simple, not flashy things. So what I mean by that is the vaccine. The vaccine is a brilliant innovation. The two mRNA vaccines has never been done before.
Yeah.
Brilliant innovations. Operation Warp Speed, as it's called, was a $12 billion investment in 6 vaccines, at least 2 of which appear to work. We don't know the safety yet, but we do have a really good idea that they work, at least in the short term. But what wasn't invested in was a national mask producing effort. The government had the power and didn't use it to produce surgical and N95 masks in mass quantity so that every person would have access, every hospital would have enough. We still have hospitals in the U.S. that lack sufficient masks. They left the state governments at odds with one another to compete, and which drove the prices of personal protective equipment up. In my town has a contract with the Broad Institute. The Broad Institute is a research institute in Cambridge, Massachusetts, that I believe is a joint effort of Harvard and MIT. And it's a phenomenal place. And they had tremendous capacity to do PCR. And they set up a testing site and got emergency authorization. And my town contracted with them. So last Saturday, I woke up with a little bit of a sore throat, not feeling really well. I slept in a bit, and my wife said, let's go get tested. We sat for 30 minutes in the car at the testing center. I got tested on Saturday at 4 p.m., and my result was in my email at 7 a.m. Sunday morning when I woke up.
Wow.
Okay, so in contrast, my daughter, who's in Philadelphia, went to a CVS, a commercial pharmacy, for a test. All her roommates went so that they would know whether, they could quarantine together safely. And the test came back 2 weeks later. And 2 weeks is a useless test. If it's not within 3 days, it really has no or very limited value. And I think that these things were achievable at a national level in the U.S., but they weren't done. So the absence of at least having PPE for our healthcare workers and having universal rapid test results available for the population, that was not accomplished, and I don't think it was that high a hurdle. So we went for the bright, shiny object, and we left the less flashy things on the sideline. And I think that, and also the freedom that we all, I think both in Canada and in the U.S., that we treasure so much, to have independent thought and make our own decisions about how we want to live our lives. I think those two things together left us very vulnerable.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
Hi, I'm Dr. Hadi Saheb, glaucoma specialist at McGill University, Montreal, and I listen to the EyeCan podcast.
Going back to the testing, Jim, what is your perception? We talk about testing, and I know you've advocated for that, and I certainly I'm in agreement with that. What do you think is the concern with all those asymptomatic carriers? Do we have a true idea of how many people are contagious without them knowing and without anybody else knowing, really, for that matter?
Well, you hear different estimates of the proportion that are asymptomatic, but it could be as high as 50%. But I think part of that is age dependent, and our data really isn't fully mature. So young people they can die from this disease, but overall they tend to be less sick, statistically speaking. And that also means that they're more likely to be asymptomatic. So depending on the age groups that are being tested, for example, if someone would do the analysis, the pre-Thanksgiving holiday in the U.S. led to a huge increase in testing. If you look at the case numbers spiked right before Thanksgiving. Why? They spiked because the disease is going up, but right after Thanksgiving, the case numbers went down, not because the disease is less prevalent, but because people were testing like crazy so that they could go home and spend time with their families.
Exactly.
So that would be an opportunity to look at the age of the person tested to determine, because I bet there were a lot more younger people getting tested before traveling home. So these are things that are not fleshed out. The CDC, the US CDC data is not sufficiently granular, what's posted, for me at least, to understand fully what the true asymptomatic rate is. But I believe it's substantial. And so the question is, I think you asked, what is the role of testing in our current phase of disease? I think testing is very important because if you know that you're positive, you can quarantine and you can avoid infecting others. I don't think that you can count on someone else having a negative test making it okay for you to not distance or mask. Because there's depending on where you read, perhaps a 20% false negative rate. Exactly. And so having a negative test doesn't save you. There's stories after stories of people who had a family gathering, 12 or 13 people, all tested, all negative. They gathered the next day, one was sick, clearly had the infection before they gathered, and then all 13 of them got sick. And it's happened multiple times. And so I think that we cannot rely on a negative test. We can rely on time in isolation. So if you literally saw no other person for 14 days, it would be astronomically unlikely for you to have the disease if you weren't, sick during that time. And if you were asymptomatically infected, you would be out of the infectious stage after 14 days in all but the most rare circumstance. There are always outliers, but for all purposes. So I think that there are ways to limit spread even when the prevalence is very high in the community. We don't know the true prevalence because the prevalence we get is based on testing, and testing rates vary depending on the circumstances, Thanksgiving holidays, community outbreaks, wherever, I can go 6 days a week and get a test 6 times a week if I want in my town because there's an outbreak, a large number of cases. And so they've decided to test 6 days a week. But in some towns, you can't get tested at all. So that will influence the perceived prevalence of the disease, right?
Exactly.
You don't test, you don't find it.
Yeah. No, those are so important concepts. One of the things you started off by saying was kind of like, just stay safe. That's our job. In a way, I often think of this in terms of like a war, and we're still huddled up in the resistance right now, just waiting for the liberation forces to come in some way. And there seems to be a light at the end of the tunnel, and you touched on a little bit of that. A phrase I've heard recently is that a light bulb was not developed due to incremental improvements on the candle, right? You had to think completely different. Right. So what can you tell us about these mRNA vaccines? To me, it is just impressive that they could come up with that type of technology. How do they work? What concerns do you have with them? What do you see in the future in terms of our ability to control the pandemic with this?
Well, there's a variety of vaccine technologies that have been attempted. I'm an adenovirologist, and there are adenovirus vaccines. The Chinese vaccine product is an adenovirus vaccine. The Russian is an adenovirus vaccine. The one out of Oxford is an adenovirus vaccine. They differ. So I'm going to segue for a minute and then come back to mRNA vaccines. Okay. The adenovirus vaccines have concerns. The one that is being used in China is an adenovirus type 5, and there's very high seroprevalence, certainly in our part of the world, to adenovirus type 5, and so you're going to generate an immune response to the vaccine vector, the backbone.
Okay.
And that, at least in experimental studies, in HIV studies, for example, and in animal studies, extensive animal studies, it tends to limit the immunity because it reduces the degree to which the vector can express its protein. Okay? So adenovirus vaccines with a common virus as backbone, like Ad5, have been sort of abandoned in most modern scientific places, but it's a very tractable system. It's easy to produce in high quantities. It's cheap. Adenoviruses don't require refrigeration. They remain infectious for room temperature. So there are a lot of economic reasons to use an adenovirus vector. The Oxford vaccine uses an adenovirus that is much less seroprevalent, with the idea that then you're not going to induce an immune response at the first immunization. And there are vaccine strategies that have been used for things like Ebola and other viruses that use one adenoviral backbone for the first injection, and then they boost with a different adenoviral backbone. And animal studies have been done that show that depending on how you organize that, you get different immune responses. And so you can manipulate the type of, and get the specific type of immune response depending on how you juggle those. Now, the mRNA vaccine doesn't have a backbone. It's literally, it's a messenger RNA that when it gets in your cells gets translated. You make a lot of this spike protein. That's the protein that is on the outside of the virus, which is appears to be the major immunogen. And you generate a lot of that, and so you get a lot of immune response. Their current strategy is to boost that with a second injection. And it's these technologies were being developed before COVID, but hadn't been really applied in this way. And as far as safety goes, I'm as curious about it as anybody else. I believe in the what we call the law of unintended consequences. But if you ask me, today, it's December 2nd, 2020, and I don't know how I'll feel on December 3rd, but if you said, do you want to use the adenovirus vaccine or an mRNA vaccine, I would choose the latter, because with that kind of efficacy and the absence of serious short-term side effects, at least that's what we're told, I think it's if you're talking about certainties, there aren't any. I'm over the age of 60, so I have an increased risk of death if I should become infected with COVID. And I think given where we are in the pandemic, I would probably be safer taking an mRNA vaccine tomorrow than I would getting COVID tomorrow. If I'm not permitted access to the vaccine until March or April, I might feel differently. Maybe at that point, the pandemic is sliding down, the prevalence is low, I feel less worried about catching the disease, and maybe we know more about the vaccine, and maybe we have some concerns, and the decision might be different. I'm not sure my hospital will allow me to make a decision. They may mandate. Right now, flu vaccine in our hospital system is mandated. That didn't used to be the case, but it is now, that you cannot work without a flu vaccine. So that could very well happen. So all of these things are very fluid. And I think the doses that are coming out in the next couple of weeks are going to be fairly limited. And I have a feeling that ophthalmologists may be excluded from getting the vaccine in the very earliest stages. And that I think hospital systems will decide to vaccinate the providers that are working with COVID patients in the ICUs as a first go. And then the discussions have been about mass vaccinations of patients in nursing homes and assisted living centers, the elderly who are most susceptible. And the toll on patients over the age of 80 and 85 has just been unbelievable. It's been devastating. And I would wait for my vaccine so they could be vaccinated.
Yeah, exactly. I think that a lot of factors go into these decisions. And I mean, it's nice that at least now we're talking about this. I woke up this morning with the headline from the BBC saying that UK had approved the use of their vaccine, or the Pfizer vaccine, I guess. And Alberta, one of the provinces here, also released some specific plans on how to address this. So it's nice that at least the conversation is beginning to shift to that. In terms of tapping into your other side, Jim, What message would you give for all of us as ophthalmologists in terms of what to look for? We're getting, it's amazing how many diseases, in spite of everybody being masked and with hand sanitizers, people are still developing pneumonias and flus and this and that. So what should we be aware of in terms of potential conjunctivitis or other eye conditions related to COVID-19?
So it's an interesting topic. I'm thinking of writing a perspective called COVID-19 in the Eye, Alternative Facts. So alternative facts was a term used by someone high up in our current administration to somehow justify an untruth as being true.
Okay.
Now, several things happened during the first surge. Many people who write had time on their hands, so they wrote more. There was panic. I think there was panic among ophthalmologists because of reports that maybe ophthalmologists were more at risk due to slit lamp exam. I happen not to believe that ophthalmologists are different from a neurologist who does a cranial nerve exam and has to sit close, or a general practitioner who wants to look in the throat, or a dentist. I mean,
yeah.
So I was always skeptical of that, but there was panic. And there also was, as people like to publish and have prominent citations and be the first to report, there was an element of, perhaps we can call it ego involved. And so a number of reports came out very early that were, I think, at the time to me, but in retrospect, I hope to everybody, ill-advised, that the peer review process was truncated to be first. Certain journals published a lot of these articles. Some very good journals, very prominent in our field. For example, there was a paper reviewing 38 consecutive hospitalized COVID-19 patients in Wuhan and reviewed retrospectively their eye findings. And the paper said that I think 12 of the 38, roughly 30%, had eye findings. And those eye findings were characterized as congestion, chemosis, hyperemia, tearing, epiphora, but each patient had one or several of those. And the conclusion was that COVID-19 caused eye problems in 30% of patients. Now, when you look at their table, only 3 of them out of these 12 had even hyperemia. The others had chemosis and secretions or epiphora. Now, as ophthalmologists, I would never make the diagnosis of conjunctivitis without a red eye. I mean, it's so obvious to me. And I know that sick patients get chemosis for other reasons. For example, third spacing, due to fluid overload or issues with their fluid management. And then we also know that some people have redder eyes than others when they, due to rosacea and other issues. And that there's things like allergic conjunctivitis, which cause red eye, right? There's red eye from eye rubbing. So there are many other reasons for hyperemia besides infectious conjunctivitis. And that paper was then accompanied by an editorial by one of the most prominent people in ophthalmology ever, who's responsible for saving thousands of lives due to findings that they've had. And then the New England Journal of Medicine Journal Watch followed with a online citation saying that the paper had identified that 30% of patients had conjunctivitis. Okay, and it was all false. I mean, again, if someone presents data that's convincing that 30% of COVID patients get conjunctivitis, I'm listening. But that paper didn't show that data. There were interesting reports, for example, from the Seattle or from the Washington State nursing homes, where all of the elderly patients, or many of them had red eyes, and there were nurses who said, we knew that if a patient had a red eye, it was going to be bad. In other words, their COVID would be bad. And those things are very interesting. And they suggest that there may be a relationship between conjunctivitis and COVID-19. There have been multiple studies showing RT-PCR results from conjunctival swabs, and some patients who are sick with COVID-19 and don't have a red eye, rarely they will have a positive swab from the conjunctiva with very low nucleic acid levels. In other words, the difference between a nasopharyngeal swab, a nasal swab, and an ocular swab is dramatic. You get a lot of viral RNA from the nasopharyngeal, less from the nose, and even less from the eye being on the verge of undetectable. In patients with a red eye, they were more likely to see virus. That again is circumstantial evidence for infection. There's one patient where they actually cultured virus from the eye. They saw cytopathic effect in their cell culture, and then they did a PCR and showed that they could recover SARS-CoV-2 from the cell culture, but they actually didn't use the proper controls. They didn't look for other viruses that cause red eye to see if maybe the SARS was a bystander and maybe it was an adenovirus infection. So the data is still soft, but if you ask me what do I believe that coronaviruses are known to cause conjunctivitis, and it wouldn't be surprising at all if this coronavirus caused conjunctivitis. There was a really nice case report in the VJO that I edited, and we never published case reports, but we published this one because they had beautiful photographs of a patient over time who developed a conjunctivitis while in the hospital for COVID. And it was we published it because I thought it was a nice demonstration of a benign, short-term follicular conjunctivitis. It lasted a few days, and that's typical of what we see with respiratory virus infections that involve the conjunctiva. Even influenza can, in some cases, have a transient conjunctivitis. So none of that would be surprising. I believe it. Again, even though the evidence is still soft, but I do get disturbed. There was a recent shout out from the American Academy about a paper that was presented suggesting, so there were 3 patients in New York that developed corneal perforation and endophthalmitis, all had organisms associated with that. Serratia, I think, and Candida, I don't remember the third. And the reporting doctor said, well, we rarely see corneal perforations like this, and all these 3 patients had COVID, and so they were somehow making that connection. I have a hard time with that because there's so many other possible explanations. And yes, COVID might be causing derangements of the immune system. It's possible, but the analysis was not there. So I think we get these sort of panicked responses in the literature and at meetings. There's a physician who will be unnamed who is promoting the use of benzalkonium chloride drops for the ophthalmologist as a prevention for getting COVID-19 from your patients.
Okay.
I think you're probably a lot better off just wearing eye protection when you see patients, and that's what we recommend to the degree that you can. So there's a lot of hysteria, and it's understandable. I mean, we have in the U.S. over 250,000 people have died from this disease, and many others who have post-COVID syndromes, the so-called long haulers, who have persistent, serious problems from having had COVID-19. Nobody wants that. I don't want anybody to get it, but I don't think injecting myself with disinfectants or taking hydroxychloroquine to be less dramatic makes any sense. I think that the effort that we had at the Academy to our web pages were so highly visited, and I learned that there are many ophthalmologists in the U.S. that have no other resource beyond the Academy for advice. Our effort was somehow to merge the limited experimental and scientific data with what's known about protective measures like masks, povidone iodine. I mean, these things have been studied well before COVID. With what's practical, what we know about the exam, about ophthalmic procedures, and to somehow merge all of that into recommendations that were practical, that were tractable, recommendations that could be followed and would make sense based on the best available data. And I think, I was reflecting on this today. So my father was an otolaryngologist, and during surgery in his very early 60s, acquired hepatitis C from a patient. And that was prior to the availability of current therapies. And he eventually died, although 2 decades later, from complications that were directly in some ways and indirectly in others related to that hepatitis. Physicians from the beginning of time have taken on some element of risk when they see a patient. Infectious diseases, all of us see patients with infectious diseases, and all of us know, if we're being honest, that we could become infected and suffer those consequences.
Exactly.
And I think that's part of what we do. And we take care of patients whose disorders could theoretically harm us. And so the way I look at it is, I'm going to reduce my risk to the degree that I can while still carrying out the things that I need to do for my patients. And there's some risk there. But there's also risk getting in my car in the morning and driving to work in Boston. If you've ever driven in Boston, you know what I mean.
I'm from Mexico City, so yes, I know.
My patients take a risk. I always say, look, there's a risk to surgery, but there's also a risk. You drove in to see me today. That was also a risk.
That's right.
So I think, we need to put all these things in context. We can't hide in the closet in life. I did say stay safe, but I don't mean by that hide from everything. I mean, take reasonable precautions. Don't, not to congregate with loved ones unless you're already living with them. So don't do it. Hopefully there's a next Thanksgiving, a next Christmas, a next New Year's for all of us, but there might not be if we're lax now. And this is the time when we really need to look ahead and say, we just have to do this now.
Yeah. Thank you for all that excellent summary, Jim. Shifting a little bit, there's another phrase I really like: never let a good crisis go to waste. And so, from a personal, academic, professional point of view, have you changed? How have you managed this crisis at a personal level? How have you grown?
Well, I don't know if it's really growth. It might be regression. For example, I don't know when I'm going to be comfortable in a crowd again. I think I've developed some agoraphobia. And I think that's going to be a very common thing, that we've now been conditioned to fear close personal contact. And how will that, even when we think that we are safe, and I do believe there will come that time, how will we sort of open up again? Will we still have those fears? I mean, there's almost like a post-traumatic stress of keeping people away from you, right? So I worry about the psychological effects on our society and whether, or what it will take for us to regain, to get to a new normal. I think that, we've certainly learned, because we've had to, the power of digital media in ways that couldn't be imagined. I mean, I don't really enjoy teaching online because I can't see the faces. I can't catch the person that's falling asleep and wake them up if I'm teaching residents because their video may be turned off. I can't get the same vibe back from the students or the people I'm speaking to. It's harder to ask them questions if I'm having a more interactive session. And I miss the human contact. So I think that although digital media is going to stay with us, and there'll be many meetings that remain online, I hope that we can be together. I mean, I really, more so than ever, miss my friends, my ophthalmology friends and colleagues, who normally I would have seen at least once a year. Now, I think that we have learned some other things, though. So, for example, at our grand rounds, you might expect on a good day when we were in person, 20 physicians, plus the residents. But our grand rounds now have triple digits because it's so easy to log in and do this. You don't have to physically be in that space. It's much more convenient, and you can do other things. You can be answering your emails while listening, which is much harder to do in an auditorium. And so people are multitasking; they're getting more involved, and attendance at meetings has gone way up. So participation, and I think that's a very positive thing. I think that residencies in the U.S., there's a movement to move to a hybrid of digital and in-person interviews. That I think a lot of the education is going to remain digital. So I think there's going to be a lot of keeping value from what we've had to do as we go forward there. I think as far as patient care, I don't know that it's that different for me, except it's hard to see facial expressions both for me and for the patient. And I spend a lot of time cleaning. I joke with my patients that if they need their home disinfected, they should call me because after hours I have a second job because I'm so efficient at it now. But I also think that you see the true measure of people in crises, and we know who's going to step up and who isn't, and that has some value. But I think that the part that worries me is really how we get started again, assuming that we can, which I really think that we should not have our expectations set too high for how quickly that might happen. There's a saying that I heard, which I find funny, related to the light at the end of the tunnel. And the saying is, be careful, that might be an oncoming train. So I think we all have to recognize that, as I said before, the unintended consequences that may come from some people being, feeling immune and perhaps that they can't be harmed, and others still fearing becoming infected. In the U.S., the vaccine is also politicized, and it's not really clear whether we'll be able to really knock the pandemic completely out, in the sense of having very, very low cases. And that creates a concern in many levels because if our hospital beds are still occupied by COVID patients, it means there's less resources for other types of care. And there are financial implications to hospital systems, reimbursement issues, and those things will have a problem. In the U.S., our cities and towns are all approaching bankruptcy. So the federal government has not supported that. So what will happen to life at the community level if that's not addressed? And how will international budget deficits be addressed? How do we come back from something that's been so costly at the financial levels?
Exactly.
As a world. In the U.S., the loss of jobs has been predominantly women. So a lot of the gains that women made have been lost because they're home with the kids who are now online going to school. So how do we get those jobs back? There's so many levels. In the communities near where I live, there is huge housing insecurity and food insecurity because people that were working for basic jobs that, hotel workers, for example, have lost their jobs. You lose your job, you can't pay your rent, you're evicted, or you can't pay your mortgage and you lose your home. And then don't have a home or a job, and now you have food insecurity. And these things are going to peak in the next couple of months. And what will that do to crime and violence? And how will that shape the social fabric that I think we all value so much? So there are real challenges ahead beyond just getting everybody vaccinated that I think are going to take leadership.
Well, Jim, this has been amazing. Thank you so much for your insights. You helped us launch our webinar series. You're now helping us launch our podcast series, and it's always so amazing to spend time talking to you. You have very interesting approaches, interest, and expertise as well. So we really value that, and we thank you on behalf of the Canadian Ophthalmological Society for that.
It's my pleasure and privilege. Thank you so much.
thank you to our guest, Dr. Chodosh, for joining us. We look forward to bringing you more episodes.
Here's what's coming up on our next episode.
Hello, I'm Yvonne Buys. I'm a professor of the Department of Ophthalmology and Vision Sciences at University of Toronto and the current past president of the COS. And I know this is difficult for me to say. I am a retired ophthalmologist. And today I'm very excited to share with you some of my experiences in retiring and hoping that that can help you if you're considering navigating the road to retirement.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
The EyeCan podcast is funded by MDF Affinity Grant. It is brought to you by the Canadian Ophthalmological Society, directed by Eric Johnson, and produced by John Allaire from Allaire Strategic Works.